refilling pressure, right heart hemodynamics, and also the regurgitant volume estimation. So let us go one by one. Let us start with stroke volume and cardiac output, which is very important parameter, hemodynamic parameter in critically ill patients, because it is the major determinant of taking the blood from the heart to the different organs, to the periphery. And many patients with low cardiac output respond very well with the fluid replacement therapy. So we have to know stroke volume, which is the amount of the blood pumped out per beat, and the cardiac output is the amount of the blood pumped out per minute. Now, where do we measure the stroke volume? Well, it can be measured across any orifice of the heart, provided there is no regurgitation and no shunt. But we do it at LVOT, at the aortic valve, because it is very easy to measure the LVOT diameter. So now let us go to the, the equations, just to make you understand the basic of the equations. Stroke volume is derived by the formula cross-sectional area into flow velocity. Cross-sectional area is pi r square. It is very difficult to measure the radius. So for the equation's sake, we consider the orifice of the heart as a circle, and we measure the diameter. So the equation then turns out to be d square into 0.785 after putting the value of pi. And for flow velocity, we measure the VTI, velocity time integral, instead of peak velocity. This is because heart is a pulsatile structure and its velocity changes from time to time. As you can see in T1 this much, T2, T3. So what we do, we trace and we integrate so that all the velocities are covered. Now, even if you don't understand, don't remember this nitty-gritty of the equations, let us see how we measure the stroke volume at LVOT. It's just in 2 steps. We can measure in each and every patient. In step 1, we measure the LVOT diameter, and in step 2, we measure the LVOT VTI. The machine does the rest of the calculation. So in the LVOT diameter, we go to parasternal long axis view. Here is the LVOT. Now, see, the D gets squared. So that is why the formula is important. So you have to be very careful, because any error of a millimeter will get squared. So what are the technical considerations we need to take while measuring the LVOT? First of all, you zoom the view. You measure it in mid-systole. If you zoom, you will be able to identify the hinge points of the aortic valve, and then you measure within 5 to 10 millimeter of the LVOT. That is the LVOT diameter. So step 1 is over. Now go to the step 2. Go to the apical 5-chamber view, put the color flow, get the cursor, put the sample volume in the LVOT, and get the VTI. And then you trace. As you trace, the machine gives the value of stroke volume by applying this formula. So it's a very easy way to calculate the stroke volume. And it is so important in the ITU, and not only for the ITU. Applying this stroke volume, you can measure the regurgitant volume in mitral regurgitation. Because, as I said, the flow across all the valves should be equal, provided there is no regurgitation. So, if we calculate the stroke volume at aortic valve and stroke volume at mitral valve, the difference of the two will give the regurgitant volume. So just 2 steps. One step is the measurement of stroke volume at aortic valve, which I have already described. In the next step, we do the measurement of stroke volume at mitral valve. For that, we go to the 4th chamber, freeze it in mid-diastole, measure the interannular line, then put the color flow, get the cursor, put the sample volume, at the midpoint of interannular line instead of at the tip of the mitral valve leaflets, which we do during diastolic dysfunction assessment, and then get the VTI. As you do so, you get the stroke volume across mitral valve. So now just difference of these two values is the mitral regurgitant volume. So this is a very, very important hemodynamic assessment. Another clinically significant hemodynamic assessment is the measurement of pressure gradient across a valve. This is to quantify the degree of valvular stenosis, and that we do by applying modified Bernoulli equation, which says that pressure gradient is equal to 4V square, where V stands for velocity of the blood flow, and that we derive from CW Doppler across the valve. This is a patient, you see, a case of severe aortic stenosis, apical 5 chamber. I put the cursor, get the CW Doppler, and then trace it. Why do I trace it? Because tracing will give you maximum velocity, maximum gradient, and the mean gradient. Now the mean gradient is 50. We would like to know the mean gradient because it corresponds well with the one measured in cardiac cath. So, and moreover, if you see the recommendation for grading of AS in AAC guidelines, it is the mean gradient, not the peak gradient, which classifies severity. If it is more than 40, then it is called severe aortic stenosis. However, you must remember that pressure gradient is not always reliable. Look at this patient. Severe aortic stenosis, hardly any opening of the aortic valve. But when I do the CW Doppler across the aortic valve, I get a mean gradient of 27 millimeter of mercury. What is happening? The LV is down. It cannot generate a significant gradient across the aortic valve, though there is severe AS. So this is called a low flow, low pressure gradient, severe AS with reduced LV ejection fraction. Here we don't go by the pressure gradient. We assess the severity of aortic stenosis using continuity equation. Well, what is that? The principle of continuity equation is that what goes in must come out. What does that mean? The volume of the blood which is entering the stenotic area must come out of that stenotic area. So we know how to measure the volume at stenotic area. And we know the stroke volume at LVOT. So stroke volume at LVOT should be equal to stroke volume at aortic valve. Now the whole thing, if you see the stroke volume at aortic valve, it is the multiplication of aortic valve area into aortic valve VTI. So whole thing divided by aortic valve VTI will give you the aortic valve area. So instead of 2 steps in stroke volume measurement, here we go by 3 steps. 2 steps for stroke volume at LVOT, and lastly the step 3 is the measurement of aortic valve VTI across the aortic valve in 5-chamber view with the CW Doppler this time. So this is the way we measure the LVOT, then we measure the aortic valve VTI and the LVOT VTI, and look at the aortic valve area. It's 0.91 square centimeter, which falls in the severe group. So and if you look at the recommendation, AAC recommendation, it's less than 1 is considered to be severe. So using this modified Bernoulli equation, we can measure the flow velocity across the VSD, as in this case, there is a small perimembranous VSD having left to right flow, and with the CW Doppler, we see that gradient is 100 millimeter of mercury. So faster the velocity, higher is the gradient, smaller is the VSD. Now, once we know that we know the pressure gradient across LV and RV, it is not very difficult to calculate the RV systolic pressure in this case. because pressure gradient at VSD is the difference between LV systolic pressure and RV systolic pressure. So RV systolic pressure will be LV systolic pressure minus pressure gradient at VSD. LV systolic pressure is nothing but the patient's blood pressure. So blood pressure 120 minus 120 is the pressure, RV systolic pressure. So this is a very, very important, because if the VSD is having low gradient, RV systolic pressure will automatically be high. Another important clinical application of hemodynamic assessment is the measurement of LV filling pressure, because we know it's the elevated LV filling pressure which gives the symptoms in HEPF, and it's a marker of poor prognosis in heart failure. So it can be measured. How do we measure it? We measure it by E by E prime ratio. Now what is that E by E prime ratio? Well, for that we go to the apical 4-chamber and get the sample volume at the tip of the mitral valve leaflets and get the E wave and A wave, take the velocity of E. Next we go to the tissue Doppler mode and we see the velocities at the septal annulus and then at the lateral annulus, where we get the E prime, A prime, take the ratio of E and E prime, both at the septal annulus and the lateral annulus, and make an average. If it is more than 14, it predicts raised LV filling pressure as per the latest AEC guideline. This is a patient, chronic hypertension, hypertrophied, LA enlarged. We see the E by E prime ratio average of septal and lateral annulus is 20.12. So this is the way we measure the LV filling pressure, a very, very important hemodynamic parameter. Next, let us go to the right heart hemodynamic assessment, where we can estimate systolic, diastolic, mean pulmonary arterial pressure, and even we can estimate the severity of pH. Now let us first see how we measure the systolic PA pressure. For that we go to the 4-chamber to get a good tricuspid regurgitation jet, and we do the CW Doppler and get the gradient. This is the pressure difference between RV and RA. So with this we add the RA pressure to get the RV systolic pressure, and in absence of pulmonary stenosis, RV systolic pressure reflects the PA pressure. Now for the RA pressure we go to the IVC, and following this chart we can put the RA pressure. If it is normal in size, more than 50% collapse 3. If it is more than 2.1 centimeter, collapsing less than 50 is 15. Apart from systolic pressure, we can measure the pulmonary arterial diastolic pressure from the PR jet. For that we go to the parasternal short axis view, get the PR. Above the baseline is the PR, just like AR. For the diastolic pulmonary arterial pressure, we measure the end diastolic. Is it over? Just three more slides. Okay. End diastolic pressure. With this, we add RA pressure from the IVC, and for the mean pulmonary arterial pressure, we see the peak diastolic pressure plus RA pressure gives the mean pulmonary arterial pressure. And also from the pulmonary forward flow, we can get some idea about the mean pulmonary arterial pressure. Looking at the acceleration time, if it is more than 130 millisecond, it's normal. Less than 100 millisecond indicates pH. And there are certain formulas where we can calculate even the mean pulmonary arterial pressure. As for example, Mohan's equation, that is 79 minus 0.45 into acceleration time. But you must remember there is reduced accuracy when the heart rate is less than 60 or more than 100. And last of all, quantification of MR by PISA method. It's very, very easy. Just like stroke volume, you remember that PISA flow is equal to flow through RA is equal to MR jet flow. Just compare it with a tank. You are opening the tank and multiple shells of hemispheres are formed. The velocity of each shell is same. The most proximal shell is equivalent to the regurgitant orifice, you see. Now, how to identify the most proximal regurgitant shell? We cannot if the scale is full. For that, we reduce the baseline to 30 to 40. Here it is 36. As I do so, I get the pizza, which is identified by the interface between yellow and blue, and I measure the pizza radius. And with the CW Doppler across the MR, I get the VTI, and putting the values in the formula, flow at pizza is equal to flow across ERO, we get the ERO value, and from there we get the regurgitant volume, and if it is more than 60 ml, it's called severe. So to conclude, I will say that there is an unquestionable role of hemodynamic assessment in echo, and we should practice it more and more, starting from the stroke volume, to get excellence in diagnosis and treatment. Thank you.
Thank you, madam. Thank you, Dr. Debika Chatterjee. In fact, this echocardiography will give you not only the anatomy, not only the function of the chambers, it will also tell us all about the hemodynamics. And the physicians who work in the cardiology or intensive care units, this hemodynamic assessment should be done by everyone. And it should be practiced, it should be come in, to it. We'll take one or two questions regarding this. I know there are so many questions regarding this. Our next speaker is Professor Tweinhoff. By the time she comes, we'll take one or two questions. If you have got any question regarding hemodynamic assessment of the echocardiography, you can ask now.
Thanks, Dr. During the measurement of pulmonary systolic pressure, please. Hello? 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 You have just shown us the measurement of pulmonary systolic pressure by TR jet in absence of pulmonary stenosis. Just tell me, in presence of pulmonary stenosis, how will calculate the pulmonary systolic pressure? In presence of pulmonary stenosis, how will calculate the pulmonary systolic?
Yeah, pulmonary stenosis does, presence of pulmonary stenosis does not reflect the TR jet gradient. So there it is very difficult. You can measure the pulmonary vascular resistance. Again, PS will be a problem. You can get the indirect evidences. Hemodynamic calculations becomes easy, difficult in presence of PS. It doesn't reflect. These are the limitations of echocardiography.
Thank you. In case of pulmonary stenosis, you will expect that there will be normal pulmonary artery systolic pressure. And unless and until there is a PDA, you cannot assess the pulmonary artery systolic pressure. This is the only way if you have got another PDA. Next, Dr. Manwar.
He has some answer.
Right, in presence of pulmonary stenosis, this is very difficult, but we can have some rough idea. If we estimate the pulmonary systolic pressure as usual and then deduct the peak pulmonary gradient, from that, the difference is the pulmonary systolic pressure. Yes.
That is rough estimate.